All right, hello everybody. I'll be presenting, my name is Matt Dickinson, and I'll be presenting on impulse control disorders, including disruptive and conduct disorders. I kind of just chose to take on the whole chapter in the DSM and just take a quick look at some of the major parts of it. There's a lot in that section of impulse control disorders. There's a lot of different parts, little subsections and things like that. But this presentation will be about some of the main elements of impulse control disorders. We'll talk about sort of what they are, historical background, going over some of the major ones, and then some reflections on treatment and cultural considerations and such. So first of all, what are impulse control disorders? This is important because they are basically a problematic self-control of emotions and behaviors that violate the rights of others and or bring the individual into significant conflict with societal norms and authority figures. So a lot of mental health disorders could be considered impulse control disorders. What we're talking about here is basically where a person has struggles with some emotional control, and then that sort of flows over into behavioral control. And importantly, then they start to cross societal norms. So like breaking, like normal things that we all go about our day and do and act in certain ways. People with impulse control disorders sort of break these barriers, and usually in particular settings, certain situations will trigger these violations of social norms, and in particular for authority figures. So there's certain triggers that will come up, and authority figures being a big part of that. So three characteristics of impulse control disorders that are sort of set it aside from other disorders in the DSM are disinhibition, so an inability to inhibit behavior, so like lack of control, you could say, sort of being impulsive, right? Impulsive control. So that's pretty much one of the main characteristics. But also excessive constraint or rigid perfectionism. So these are also very similar in certain ways. Just sort of the person is overly constraining of themselves and their behaviors. But also negative emotionality. So just exhibiting some anger in particular, but lots of different negative emotions, sort of bubbling up to a point of a lack of control or lashing out or something like that. Which brings it back to a really important point for this presentation and this subject, which is that most impulse control disorders we're talking about for children and adolescents. So most of what I'm going to be talking about are diagnosed in children and adolescents. So these behaviors happen in school settings or family settings, and then they start to cause issues, and that's when a clinician is brought in or something like that. Also with adolescents. The exception is antisocial personality disorder, which is listed in the personality disorder section of the DSM, but it often, with conduct disorder in particular, sort of leads into antisocial personality disorder. So those things are sort of connected. So antisocial personality disorder is sort of like the adult version of impulse control disorder. Although it doesn't mean that these other impulse control disorders can't be diagnosed in adults, but they're just by far most often diagnosed with adults. Interestingly, these disorders are more commonly seen in males and females. There's a lot of reasons for that. We'll sort of come back to that a few times in this presentation, but for some reason, males exhibit these behaviors more often than females, and yeah, there's a few reasons why that might be. Yeah, and these behaviors are exhibited with the distress in a social context. So, like I said earlier, just like school, family, work, this is where these things start to come out specifically with certain triggers and things like that. So what's really important, and again, we'll come back to this again and again, but that when diagnosing these disorders, that it's critical to take into account the age of the person, the gender, and the culture, of course, always, but with, in particular with these disorders, especially because they're usually with children and adolescents, you know, these are times when people are developing really fast, there's lots of changes, and we don't want to apply the same strategies for diagnosing adults with children, because of these developmental changes, cultural things that we put on kids as far as gender and culture. So it's just critical that we're, as counselors, really considering these things and development and things like that. Like, for instance, just, you know, what we expect of a 2-year-old in terms of the social norms is pretty different than what we expect of a 4-year-old, 6-year-old, 8-year-old. You know, so this is important. So we need to make sure that we're always looking at developmentally what's appropriate. So also another factor is that these behaviors, you know, when we're talking about the general diagnostic criteria, just to go back to the slide overall here, this list on the bottom here these are like sort of the general diagnostic criteria of all of these disorders that I'm going to talk about. So it is a lot of different disorders that do all come back to that self-control piece, but these are the factors that are sort of across the board that we want to look at. So, you know, these behaviors are not exclusive to psychotic, substance abuse, or depressive or bipolar disorders. So these are other things that come into play that we need to make sure we isolate them out if possible. Again, criteria, and also criteria not met for disruptive mood, dysregulation disorder, not attributed to substance abuse, very similar to the piece above. And then just to mention that morbidity is really common. So it's common to have like conduct disorder and ADHD or something like that. These are really common. So just that's something to keep in mind here. So I'm going to go through these more specifically, but just to go over them. Oppositional defiant disorder, intermittent explosive disorder, pyromania, kleptomania, and conduct disorder. These are sort of all in that chapter, impulse control disorders in the DSM. And as I mentioned earlier, ADHD, just a second ago, ADHD is often seen with impulse disorders, so they often go hand in hand, they're comorbid. But it's important to remember that ADHD is about attention rather than emotion or behavioral regulation. So those things can confound each other, and it's important to piece those things apart. So, and the difference between these ones, in particular, conduct disorder, intermittent explosive disorder, and oppositional defiant disorder, is that they differ on the regulation of emotions and behavior, those two things specifically. So, you know, conduct disorder is poorly controlled behaviors that may be the result of emotions, whereas intermittent explosive disorder, maybe it's about behaviors or about emotions that come out through behaviors, if that makes any sense. Whereas oppositional defiant is sort of in between. So you have sort of the spectrum of like is the emphasis of the symptoms on the emotional side of things and emotional regulation, or is it more on the behavioral regulation side? So that's sort of what differentiates these within impulse control disorder. I guess I wanted to just point out before I move on that within these diagnoses, it's important to, there's a few questions that Goldman in 1998 set forth to go along with your assessment that you want to make sure you ask. So it will help you hone in on, which one of these it might be, but also about these confounding factors and what might be in play here. So these questions that he put forth were, where does the problem originate? So it can be hallucinations, it can be environmental, which is a whole area like parents, school, things like that. Is the problem related with a reaction to a specific stressor? So this is critical. So if there's something specific that causes the impulse control to go away, we want to know about that. And then third, what areas are affected or impaired by the problem? So maybe this child is having trouble socializing because of these issues, but they're doing fine in school, or they're fine at home, or we want to sort of isolate where the problems are coming in to the person's life. And then fourth, what do the symptoms intervene with functioning? So like where functioning wise do these symptoms express themselves, and where do they intervene? So a little bit on the background and history of impulse control disorders. So I guess first of all, it's important to note that impulse control has been, or just trying to understand where impulsivity comes from, has been a part of medical science and psychological science forever, for as long as we know. So Hippocrates, the founder of modern medicine, he had this theory of personality being made up of 4 humors. And then, he noted that impulsiveness was part of too much yellow bile in the person. So supposedly, like he had this personality system, and this was part of the structure that he put forth. So just a few things here on this history here. So, and then phrenology. We have this picture here. This is from phrenology, where people thought that you could tell by the shape of the skull what someone's personality and behavior would be like. And so we had this Cuban phrenologist, Uligo Prieto, who said that there was an impulsive region of the brain, and it was one of 6 of these regions that he described. And then in 1845, Jean-Étienne Dominique Esquirol was the first to describe impulse disorders in his book. And so we've been sort of diving into that since. And in my research, there was 3 overall perspectives on impulsivity, just sort of like to step back a little bit and not look at it maybe as a disorder, but just like, what is impulsivity? What does it mean to be impulsive? So there's 3 kind of takes. So like it's like a facet of someone's personality. And then second, it's like a behavioral thing, like something specific happens, and then this is a specific reaction, sort of looking at it from like an animal behavior perspective. And then there's the clinical, which is more perhaps what we're focused on here, which is more like parts of the brain, parts of behavior, kind of taking it all together and where does it inhibit people from functioning in society? Um, just mentioning that the idea of impulsivity itself has been challenging to measure at all. But it's really important that we do so in order to study this and understand it better. So there's a paper that put out this idea of momentary impulsivity scale. It's like a way that they can track throughout someone's day how like their impulsivity level, and it's found to be fairly accurate, where they could compare impulsivity within one person. So from day to day, they could do a comparison, and then they could do comparisons between people as well. So this was helpful, although this scale probably not useful in a clinical setting so much, but in terms of research and figuring out where this stuff is coming from, these kind of scales can be really important in terms of figuring this stuff out. So oppositional defiant disorder, let's dive into some of the diagnostic criteria for some of these disorders. So these are the criteria in the DSM. So angry and irritable mood, argumentative and defiant behavior, vindictiveness, and these symptoms lasting for 6 months or longer. There's a few specifiers in the DSM that go from moderate or mild, moderate, and severe, and these are really based on the number of settings that these symptoms are exhibited in. So settings being like school or home, those could be 2 settings, or like sports, I guess, could be another. Like if a child at soccer practice, they exhibit these behaviors. So if it's mild, it's probably just 1 setting. Moderate is 2, and severe would be a bunch of settings. So these are some of the criteria. Again, so this is sort of middle of the road, like in terms of the impulsive disorders. This one's kind of it has a mixture of behavioral stuff and emotional stuff, and the prevalence in society is around 1 to 11%. So it can be a pretty large amount. They had a mean of 4% in the DSM. Oh, and yes, so oppositional defiant disorder has a pattern of developing into conduct disorder over time, and children with OPD, oppositional defiant disorder, have been shown to have a higher risk for anxiety and depression. And like the other conduct impulse disorders, this one it's rare. It usually is onset in adolescence and rare to emerge in adulthood. So intermittent explosive disorder. So this one's impulse, anger-based, verbal or aggressive or physical aggression occurring twice weekly or for 3 months, or 3 outbursts resulting in destruction of property or injury within a 12-month period. So we're talking about more behavioral stuff here. And it's important to note that the aggression itself is outside of the proportion of provocation. So that goes back to the developmental stuff, cultural stuff, age, gender, all that kind of stuff. This is where we want to, apply that and think about where this person is with those contexts put into place. But these aggressive outbursts are way out of proportion to the normal situation. So it could be like, a kid in school, he's the last in line for lunch or something like that, and has an outburst where he hits a kid. and this happens a few times throughout a certain period, that would be way outside of the normal provocation. It's important to note also that this aggression itself is not premeditated. So there are some forms of impulse disorder that may be premeditated, but this one is not. So it's, so it can't be that they're seeking, this child, adolescent is seeking more money or power or sort of anything like that. Sort of, they get triggered to have this outburst of anger, and there's not really any reason behind it except for they need to this anxiety builds up and boom, something happens. But it has nothing to do with their thinking about the behavior beforehand and then executing the behavior. So, and individuals with this to be diagnosed have to be at least 6 years of age. That goes back to the developmental stuff that we've been talking about. And the prevalence is 2.7%, so more common in people less than 40 and individuals with high school education or less. So less educated people are more seem to have higher levels of intermittent explosive disorder. And conduct disorder. So conduct disorder is, these are the characteristics, so repetitive and persistent pattern of infringing on rights of others and social norms. Characteristics include aggression, bullying, fighting, weapons, brandishing weapons, cruelty to animals or people, mugging, rape or sexual assault, destruction of property, fire setting, or deliberate destruction, deceitfulness or theft, burglary, lying, shoplifting, serious violation of the rules, so like truancy, not going to school, running away from home, etc. So these are sort of like, again, goes back to breaking those social norms, usually associated with authority figures and things like that. And then, in the DSM, we're talking about some specifiers. So we're talking about, is it a childhood onset, which is the most common, or childhood onset or adolescent onset? These are the most common. Then unspecified may mean that we're talking about not enough information here. And for childhood, for childhood onset specifier, we're talking about one symptom before age 10, and then adolescent, no symptoms before age 10. And then, so for these, and then the second type of specifier here is limited prosocial emotions. So these are within a conduct disorder. You can do lack of remorse / guilt, callous / lacking empathy, unconcerned about performance, or shallow / deficient affect. So these characteristics would be a specifier on specific kind of conduct that's being broken here. And these would last for 12 months and be present in multiple relationships or settings. And with this conduct disorder, we're talking about the individuals more likely to plan these aggressive behaviors as opposed to intermittent explosive disorder, which is unplanned. So folks with conduct disorder are maybe planning some of these aggressive behaviors. And with conduct disorder, with any of these disorders, but conduct disorder specifically, it's really critical to gather as much information from other sources as possible. So if it's suspected that it might be going down this road, you definitely want to pull in parents, teachers, other people to gather more and more information as possible. And conduct disorder turns into antisocial personality disorder when the person is 18 or over. Prevalence for conduct disorder, 2 to 10%. Pyromania and kleptomania, I just threw these onto one slide. They're kind of similar in some ways. They're kind of like they're specific forms of impulsive behavior and these are pretty new to the DSM, and they're sort of self-explanatory. But pyromania being obviously that this person is specifically impulsive around fire. So multiple episodes of deliberate fire setting, and then it's important to note that the fire setting behavior isn't associated with some sort of social or political purpose, because those things come up sometimes, and it's important to think about culture here. Perhaps the fire setting is part of cultural behavior. Experiencing the fire, lighting or watching relieves tension, and that's sort of across the board with a lot of these impulsive behaviors. That's about releasing tension here, but specifically with the fire. And this one's challenging to diagnose and separate from the other ones, and it's pretty rare. Kleptomania, stealing without having the need to do so. So the key thing here is that the object itself has nothing to do with the behavior. So it's about taking something without the actual value of the object having any meaning there. And similar to pyromania, it's about controlling anxiety. So the object is taken, tension is relieved. Interestingly, I found that a study that showed that 8% of shoplifting is associated with kleptomania, which is a huge percentage when you think about it. When you consider all the people, all the enforcement of that's happening, people are getting prosecuted with that may or may not have kleptomania, and it may be a mental disorder as to why they stole something. It may have nothing to do with the value of the object. So risk factors here, just temperamental personality stuff can make it more likely that a child might experience these disorders. Most importantly, environmental stuff. It's like the word environmental is just so big, but we're talking about like abusive parents, divorce, moving, acculturation, the list just goes on and on and on and on. Death of a sibling, all kinds of things. And really it's important to note here that, especially with children, that the, anxiety, depression, as we notice it in adults, is pretty different when it's expressed in kids and adolescents. So sometimes these behaviors, these impulse disorders, they just look so much different, being that they're children and adolescents. They might be depression and anxiety sort of way down there, but they're expressed so much differently. That's just something to note there. Yeah, and genetic and physiological risk factors for sure. So there's definitely lots of evidence to suggest that these disorders are passed down genetically. Studies on twins have shown that, and there's also lots of, every single one of these disorders has physiological elements that's not a part of diagnoses, but brain scanning and things like that show lots of different pieces of this. So for instance, they show lots of neurological markers, neurobiological markers. So lowered heart rate or skin conductivity, reduced basal cortisol reactivity, abnormalities in the prefrontal cortex or the amygdala, serotonin imbalances. There's definitely a lot of markers that can be seen across and correlated with these disorders. But again, it's correlation without causation, so we don't know specifically where those are coming from. But if you're talking about a risk factor, then a kid who's exhibiting some of these physiological things may be at higher risk for these disorders. And just to mention again that ADHD is common with impulse disorders. So, another risk factor could be that a child is exhibiting ADHD behaviors and they're going to be at higher risk for having impulse disorders, especially, going back to the environmental stuff. If the environment changes, let's just throw out a common one, like parents get divorced, kid has ADHD, parents get divorced, they're at higher risk for these impulse control disorders. So methods for diagnoses. Pretty much we're talking about clinical assessment here. I didn't really, like I said, you can do, there's brain scanning stuff, but I don't think anybody's ever been diagnosed with impulse disorders based on a brain scan. So we're talking about a clinical diagnosis that's following the DSM criteria. And these are some of the things that are important to keep in mind during this assessment. So that we want to like check these off our list as we're going through and make sure that we got these all covered when we're thinking that a kid, a child, adolescent might be having one of these disorders. So definitely want to hear the problem from the individual, regardless, what's going on. We want to know what they're thinking about the situation, what their experience is like. We want to listen to them and take that into account. The specific behaviors of the problem, of course, like we want to know what specifically is going on here. The intensity, frequency, duration, specific environmental and contextual circumstances. This just is taking on that's a huge one right there. Just a lot of, we want to just have a timeline, sort of like we could look at the ups and downs of the problem and maybe correlating that with specific things that are happening in their life. And then that's going to go to the functioning, areas of functioning. So school, socializing, physical, maybe even physical stuff, things like that. We want to know about previous coping skills used. So maybe this has been something that's been more minor in the past, that has been dealt with in certain ways. And then maybe there's some useful information there. Any previous and current medications or interventions used. So again, so we want to know that for sure. Developmental milestones is related to the problem. So when we're dealing with young people, there's a lot of development happening, and oftentimes it's happening very, very fast. And so we want to put that into our timeline on what's happening, how development has been going, and then relate that to the problem areas. And then this assessment of the family system. This might be one of the most important things here with looking at these impulse control disorders with young people. The family system is going to be key to assessing the problem, but also treatment, which we'll talk about in a second. Cultural factors affecting treatment and compliance. So definitely this too, how we look at, for instance, girls and boys. There's a lot of cultural things that we're placing on people based on their gender. And these might be affecting how we want to treat this disorder. So this is how we want to get into our diagnosis, is sort of taking this big picture approach. And just a note too, so we really want to draw in, like, one of the methods, a method for diagnoses is going to be to draw in information from as many sources as we can. The child or adolescent might not be the best source, neither might their parent, but maybe their guidance counselor at school, or a teacher or coach or something like that. If it's ethical to do so, we want to bring them into the process as much as possible to have the most accurate picture and diagnoses that we can. Cultural and ethical considerations. So definitely, like I kind of just mentioned it, but gender differences in expression of impulse disorders. So it's been noted that boys are often exhibiting these behaviors at much or higher frequencies than girls. But I guess an important consideration here is that, but are they? Because maybe it is that they exhibit, maybe girls are exhibiting the behaviors, but they're functioning better or something like that. This is something that I've been reading about, and that I think is an important question to ask is, maybe it's the detection itself of the disorders is better for boys, or they're just more, they exhibit the behaviors in ways that are easier to detect is kind of what I'm saying. So I guess we want to just make sure that we're thinking about where our biases are in detection and for diagnoses, and to just check those at the door if we can. And just, so some of these impulse disorders are more common have been shown to be more common in the US than other places across the world: Asia, Middle East, Romania, Nigeria. So this suggests that probably more likely we're talking about a sampling problem, but it also could be a cultural thing. It could be that something about American society sort of elicits these behaviors more often, perhaps. Important to consider. So any kind of treatment strategy is going to need to incorporate these cultural competencies, because we're going to have to work with, with young people. You're not going to be working with the individual as much as you are with the family and with the community and school, things like that. And all those things are going to bring in cultural considerations, depending on, no matter who it is, and that you want to be mindful of those things. The DSM recommends using the cultural formation interview, so you can find that in chapter 2 of our textbook. Treatments. So there's a bunch of different treatments. Again, this is a broad category of disorders, and it's going to be very specific to the young person that you're working with. But cognitive behavioral therapy has been shown to be very effective. A lot of the impulsive behavior is a cognitive thing. So it's like drawing awareness to the cognition that leads to the behavior. CBT therapy is just perfect for that, for addressing those things. But sometimes that might be, just from my readings and my understanding, that might be too much, especially for a young person, to explore things like your core beliefs and things like that cognitive behavioral therapy is going to want you to do. CBT might be more appropriate for adolescents, but maybe play therapy, art therapy, nature therapies are much more appropriate for kids. I definitely found a lot of evidence to suggest that exposure to nature can pretty substantially lower impulsive behaviors. So this might be something, a treatment. It might be hard to prescribe nature, but maybe there's some way to expose someone to the natural world in gentle ways that can be helpful, because there is a lot of evidence to suggest that it is. Family therapy is key. Considering that the behaviors might be coming from the family. So it might be an abusive family relationship, and the kid is exhibiting the behavior due to that. So incorporating the family in family therapy may be the most important thing, instead of focusing on the individual that's exhibiting this disorder. Broaden it out and look at the family system. That can be critical, and along with that, parent training. And I guess I wanted to mention that sometimes what can happen is that we do start blaming the parents, um, but helping them helping them with strategies and methods for dealing with impulsive behavior might be one of the most important things. Dealing with stress and anxiety coming from their child having outbursts and things like that. And pharmaceuticals have their place. There's a lot of discussion about pharmaceuticals in the literature with children. Um, my personal inclination is that those should pretty much be avoided at all costs. You know, the kids who are exhibiting these disorders, they often express that they feel that they have little control over their own lives. It's interesting because they're impulsive and they express that they don't have control. That makes sense. Um, and I think the pharmaceutical route sort of like feeds into that fear. And so it's like, okay, so take this pill and be controlled by the adults in your life. It feels to me as if it's another element of control, where I guess my gut tells me that the kids who are experiencing, a lot of kids who are experiencing these disorders, they're expressing their lack of control over their own life. However, so these pharmaceuticals, they definitely have their place, and for sure, children, the adolescents that are suicidal or highly aggressive or dangerous, there's a lot that can be toned back. Aggression specifically can be toned back here. I guess for treatment, as far as like the sort of some important goals here are developing self-control and then some basic skill building and training. Just in it kind of goes back to the CBT, but just developing that awareness and that ability to know when maybe things are about to be triggered, and knowing perhaps some other skill habit that can be brought in to replace that. Okay. So that's going to wrap up my presentation here. Thank you so much for watching. Hopefully it was helpful for you in understanding the disorders. I know it's like a big group of disorders in the DSM, and it's one of the most recently edited chapters in the DSM. And I'm sure there will be lots of more edits in the future and lots of more research that needs to be done. Here are my references, and thank you for watching.